Hello, and a very good afternoon to all our viewers. Welcome to today's session on fertility and PCOS. About 80% of anovulatory infertility cases are caused by polycystic ovarian syndrome. Its treatment initially consists of preconception recommendations such as lifestyle modifications, folic acid therapy to lower the risk of fetal neural tube abnormalities, and quitting smoking and drinking. To discuss more on this topic, we have with us today Dr. Manju Jilla. Dr. Manju Jilla has over 25 years of experience in assisted reproductive technology and has performed over 10,000 laparohysteroscopic surgeries in her career. Her expertise includes transvaginal sonography, gynecological endoscopic surgery, color Doppler ultrasound, intrauterine insemination, in vitro fertilization, and immunotherapy for recurrent pregnancy loss. Dr. Jilla is keenly interested in IVF and intracytoplasmic sperm injections and is an expert in complicated procedures like myomectomies and laparoscopic endosuturing. Welcome, ma'am. It's an honor to have you with us today. You may please share your screen and begin your presentation.
Welcome everyone to this session today. I thank Dr. Plus for inviting me to speak on fertility in PCOS, assessment and treatment of infertility in patients of PCOS. Almost every day, all gynecologists and even the routine practitioners must be seeing patients of PCOS. And the main thing that brings them to a gynecologist is irregular menstrual cycles and infertility. But before we start giving them ovulation-inducing drugs, it's very important that we do a good preconception counseling in these patients. Majority of the PCOS patients are obese. So we have to see that we bring their BMI down to between 25 to 30 at least before we embark on a fertility treatment. Consistent and routine preconceptional care consists of, in these PCO patients, would consist of checking their weight, their blood pressure, asking them about a history of smoking, alcohol, what type of diet they are taking, what is their nutritional status. We should supplement them with folic acid, and if they are obese, with higher doses of folic acid. We should tell them about the importance of exercise, especially resistance exercises, sleep, and mental and emotional and sexual health. This should be considered before we embark on the reproductive treatment or the fertility treatment. These patients can also have chronic conditions like diabetes, hypertension, anxiety, depression, and so these should be treated prior to fertility treatments. Once this is done, we then focus on inducing ovulation. So PCOS patients, the main reason for infertility is that one follicle does not grow and ovulate like all non-PCO patients who have regular menstrual cycles. So in these patients, there are a large number of small antral follicles which do not grow because they do not get the required amount of FSH. So before we embark on inducing ovulation in these patients and waiting for them to conceive, is it essential that we look at the tubal patency? Now, tubal patency evaluation depends on the individual patient's history and our findings on examination. So if she has a history of pelvic inflammatory disease in the past, leukorrhea, pain in the lower abdomen, then she has dysmenorrhea, dyspareunia, if she has a history of fever in the past, if she has any sexually transmitted diseases, then in these patients, tubal evaluation will be a must. But if she's a clear-cut case of a PCO without any problem at all, no infection, clean pelvis, clean ultrasound findings, just polycystic ovaries, then we can just move ahead with inducing ovulation. Because looking at the tubes may make the patient a very painful procedure like angiography or a surgical procedure like a hysterolaparoscopy, which may not be required in a patient who has no other problem than anovulation. And if after 2 or 3 cycles of ovulation induction, she does not respond or she does not conceive, then we can go in for a hysterolapro or a angiography. Now, about once we've either seen the tubes or we are sure that the tubes are patent, then we go ahead with inducing ovulation with ovulation-inducing drugs. We have 2 good drugs at hand. One is letrozole, which is an aromatase inhibitor, and second is clomiphene citrate. The main principle of both these drugs is to increase the FSH secretion from the pituitary. And how letrozole is doing it is that we all know that in the ovary, the theca cells produce androgens, and these androgens get converted into estradiol. And if as estradiol levels start rising, FSH levels start falling. And we want to keep the FSH levels high in order to bring about ovulation in PCOS patients. Now, with aromatase inhibitors, that is letrozole, what it does is it stops the conversion of androgen to estrogen in the ovary. So as the estrogen levels in the ovary, production of estrogen from the ovary falls, the pituitary starts secreting a lot of FSH. And this FSH brings about growth of follicles in the ovary. Advantage of letrozole is that it brings about monofollicular growth of monofollicular ovulation. That is, one follicle grows, which is good. We will not have multiple pregnancies. Secondly, aromatase inhibitors do not have an adverse effect on the endometrium, and they have very little side effects. They are very well tolerated. So this has become the first drug of choice for inducing ovulation in PCOS patients. It is given from the 3rd to 7th day. It is given in a dose of 2.5 milligram daily. Some of the obese patients may require 2.5 milligram twice daily, and some resistant patients may require letrozole to be given for even 10 days before they show a good response. And from the last tablet of letrozole, the patient usually ovulates on the 7th day. That is, if we have given letrozole from day 3 to day 7, then she will ovulate on day 14. We can ask them to time intercourse on day 14. So that is about aromatase inhibitors, and they do not produce any adverse effect on the fetus, as this was thought earlier. The chances of any fetal anomalies with letrozole are negligible. Now we come to clomiphene citrate and metformin. Now, clomiphene citrate, we know, is a selective estrogen receptor modulator. It blocks the estrogen receptor alpha in all the cells of our body and also in the pituitary. So pituitary fails to understand the presence of estrogen in the blood and starts secreting large amount of FSH. And this FSH acts on the ovary and starts producing multifollicular growth. That is, 3, 4, 5 follicles will start growing together. The clomiphene citrate also has an adverse effect on the endometrium, and endometrium becomes very thin and scanty. Therefore, the problem with clomiphene citrate is, although the rate of ovulation is 80%, the conception rate is only 20% because of the negative effect of clomiphene on the endometrial echo pattern. Implantation usually fails. Now, adding metformin to clomiphene. So clomiphene citrate could be used in preference to metformin in PCOS patients. We know that metformin only reduces or sensitizes one to insulin. It is an insulin sensitizer. But clomiphene is the main drug to improve ovulation, clinical pregnancies, and live birth rate. The risk of multiple pregnancies increases with clomiphene citrate use. And in combination with metformin, therefore clomiphene cycles may require ultrasound monitoring. Almost all ovulation-inducing cycles require ultrasound monitoring from the 10th day till the day of follicular rupture. Metformin, some patients may ask, why not use only metformin? Actually, metformin is an insulin sensitizer. It reduces the theca cell mass and improves the sensitivity of the ovary to ovulation-inducing drugs and to FSH. So adding metformin is a good practice with ovulation-inducing drug, but metformin alone as an ovulation-inducing agent is not as effective as letrozole and clomiphene citrate. But many women, after they start metformin, may just conceive spontaneously without addition of these aromatase inhibitors or even without any monitoring. So women should be counseled about the gastrointestinal side effects of metformin. The dose of metformin is 1500 milligrams every day. The dose is 1500, and along with metformin, we should give 1500 micrograms of vitamin B12 because long-term use of metformin causes severe B12 deficiency. So whether we should use clomiphene citrate alone or clomiphene citrate with metformin, or whether we should use clomiphene citrate and or letrozole. So clomiphene citrate combined with metformin could be used rather than clomiphene citrate alone in PCOS and ovulatory patients and no other fertility factors to improve not only the ovulation rate but also the clinical pregnancy rate. Clomiphene with metformin could be used rather than metformin alone in PCOS patient. Again, this improves the live birth rate. So we feel alone clomiphene or alone metformin, instead of that, metformin with clomiphene is a better choice. And between clomiphene and letrozole, it is letrozole which is a better choice because it causes monofollicular ovulation and it gives better clinical pregnancy and live birth rate. And there is no difference in the abnormality rates with letrozole, clomiphene, or those who naturally conceive. So these drugs do not produce any teratogenic effects on the fetus. So in women with PCOS, if oral ovulations fail, then the next line of treatment is either polycystic ovarian drilling or use of gonadotrophins. So one of the two would be the second line of treatment. With PCOS who are anovulatory and infertile, with clomiphene who are clomiphene resistant or do not respond even to aromatase inhibitor, and they have no other fertility factor, following counseling on higher live birth rate and higher multiple pregnancy rates with gonadotrophins, this should be done to the patients. That we must tell that there are risks of gonadotrophins while they are being used for ovulation induction in PCOS patients. So they are a second line of treatment. They should be used only after the oral ovulations fail. So PCOS who are anovulatory and infertile with no other infertility factors and who have failed the first line of oral ovulation induction, gonadotrophins should be used. Patients should be well counseled before using gonadotrophins because the cost of gonadotrophins is high. Ovulation induction with gonadotrophins, although may give higher pregnancy rates, costs are many times more than oral ovulations. The gynecologist using gonadotrophins should be an expert and aware of using these drugs carefully. The degree of intensive ultrasound monitoring that is required should be explained to the patients because patients may take 20 to 25 days to ovulate and would need to keep coming for ultrasound evaluation of the follicle. A low-dose step-up gonadotrophin protocol should be used to optimize the chance of monofollicular development. And the implications of potential multiple pregnancies also should be explained to the patients. Apart from that, the chances of ovarian hyperstimulation syndrome should also be told to the patients before starting gonadotrophin therapy. It's always better to take a written consent from the patient that she is aware of all these things and then start gonadotrophins. There appears to be no difference in the clinical efficiency on any of the available gonadotrophin preparations. We all know that the market is flooded with urinary gonadotrophins. Then we have recombinant products like Gonalef, and now so many biosimilars of FSH are coming. But there has been no difference in the efficacy of either the urinary or the recombinant products. And this should be explained to the patient. And depending upon her capacity, you can decide what you are supposed to or what you want to use for her. The only thing is urinary gonadotrophins can have certain side effects like some anaphylactic reactions or some adverse reactions because they contain a lot of other human proteins which are not there in the recombinant products. When using gonadotrophins, if we see that multiple follicles have started growing, then it is better to cancel the cycle than to put the patient into the mess of ovarian hyperstimulation syndrome and multiple pregnancies. Live birth rate, clinical pregnancy rate per patient, and ovulatory rate per cycle are higher with gonadotrophins than with clomiphene citrate. Low dose protocol should be used to optimize the chance of monofollicular growth. Cycle monitoring and drug costs coupled with multiple injections will influence the choice of use of gonadotrophins. Laparoscopic ovarian drilling. This is also a second line of treatment where oral ovulations have failed. And laparoscopic ovarian drilling should be given when in those patients where we feel that puncture of these follicles, removal of the androgens of these from these ovaries may allow the patient to respond to oral ovulagens. The patient can go for a laparoscopic surgery where tubes are evaluated, endometrial cavity is evaluated with a hysteroscopy, and then the ovarian cortex is punctured with a monopolar cautery. Patients should know that this is a surgical procedure, then its cost is higher than the oral ovulation therapy. Expertise is required for the gynecologist to do such procedures, and there are intraoperative, post-operative risks which the woman should be explained before going for laparoscopic ovarian drilling. Now, supposing the patient doesn't respond to the second line of treatment, that is use of low-dose gonadotropins or laparoscopic ovarian drilling. So then these patients can be offered assisted reproductive techniques like IVF and ICSI. Actually, if they ovulate with oral ovulagens and gonadotropins, yet they fail to conceive, then we can put them as cases of unexplained infertility and take them up for IVF or ICSI. In women with PCOS undergoing IVF or ICSI treatment, is the gonadotropin releasing hormone antagonist protocol or agonist protocol most effective in improving fertility outcomes? Actually, many patients who did IVF for PCO in the pre-antagonist era, the greatest risk that they faced was of ovarian hyperstimulation syndrome. And as the antagonist was introduced in the world, all PCO patients were very safe because they did not suffer from the ovarian hyperstimulation syndrome because no HCG was used in these patients for the final trigger. It is HCG given in PCO patients that leads to release of VEGF and therefore dangerous ovarian hyperstimulation syndrome where the ovaries enlarge many times more than their size, and there is fluid leak in the third space, that is in the peritoneal cavity and in the pleural cavity. The patient may have respiratory difficulty. There can be hemoconcentration, polycythemia, thromboembolic disorders. There can be renal shutdown, electrolyte imbalance, and the patient may need an ICU. So we do not want to land our simple, straightforward patient into such a dangerous complication. Therefore, we use the antagonist protocol with the agonist trigger in patients of PCO who are undergoing IVF or ICSI. So they have said the same thing in the guidelines that gonadotropin releasing hormone protocol, that is antagonist protocol, it is the recommended protocol over the long agonist protocol. And use of antagonist protocol in PCOS is recommended as it enables the use of agonist trigger. See, when we use long agonist, we cannot give a agonist trigger. We have to give a HCG trigger. But when we use the antagonist, we can easily give the agonist trigger. The second part is, once we take out the eggs and we produce our embryos, if we transfer these embryos in the same cycle, again, these embryos will start producing HCG, which is the culprit of OHSS, and patient will land into secondary OHSS. So if we want no OHSS at all, we should not transfer the embryos. We should freeze the embryos and transfer them in the next non-stimulated cycle where only the endometrium is prepared. So this is called as a cycle segmentation antagonist regime in patients of PCOS in order to avoid the risk of ovarian hyperstimulation syndrome. Now, again, we are speaking about the same thing, that what is the trigger type. So the trigger we use here is agonist trigger, which causes the release of LH from the pituitary, and we do not use a HCG trigger for the final maturation. The second meiotic division of the oocyte requires a large amount of LH or its surrogate HCG. And in the antagonist protocol, we use LH because we use agonist because the pituitary LH does not produce ovarian hyperstimulation syndrome. Now, what about in vitro maturation? So, in vitro maturation was used in the era when we did not have this cycle segmentation, we did not have good freezing protocols, we did not have agonist trigger. In order to prevent the chances of ovarian hyperstimulation syndrome, in vitro maturation was used. However, the effectivity and the quality of results with IVM are much lesser than the antagonist protocol, agonist trigger, freeze all, and transfer in the next cycle. Therefore, this procedure of IVM has fallen back in the ART world. Now, which is the gonadotrophin of choice which we'll use? Will you use HMG or will you use FSH? So FSH is the drug of choice because we already know that PCO patients already have a lot of LH. Their basal LH levels are very high. And we also know that the products available in the market, which say HMG, means they write FSH and LH activity. It is FSH and HMG. And we know that the LH activity in HMG lasts for 36 hours. So we will go on concentrating LH activity if we use HMG in patients of PCO. Instead of that, we should be using LH. We should be using FSH, either pure FSH or urinary FSH. And we should avoid adding HMG preparations if the patient is responding well to pure FSH and if she is a PCO. Exogenous LH is not required. I told you that LH is actually HCG with LH activity, and which may reduce the quality of our oocytes if we use it in ovarian stimulation compared to using pure FSH. Now, what about the adjuncts? While we are doing IVF, should we add metformin? So, adjunct like metformin therapy could be used before, during, and the stimulation in women with PCOS undergoing IVF and ICSI treatment with GnRH agonist long protocol to reduce the risk of ovarian hyperstimulation and miscarriage. But we do not use long protocol in PCOS now. In antagonist protocol, also we can use metformin. If using metformin, the following would be considered. Commence metformin at the start of the agonist treatment. Gradually titrate metformin to bring it to the level of 1000 to 2500 milligram daily. And stop metformin therapy at the time of pregnancy test, or once she gets a pregnancy test positive, stop the metformin, or once she gets her period, the metformin therapy can be stopped. So even with the antagonist or the agonist protocol, metformin can be given. And this may only help the patient in general. They say that it reduces the chances of miscarriage in patients of polycystic ovarian disease. Again, here we are with IVM, and we've already discussed that IVM does not give the live birth rate, which IVF ICSI cycle segmentation, freeze all, and transfer in next cycle gives. That's why IVM is still now it has a place in research rather than in our day-to-day practice with our patients with PCOS. So I think with that, I end the fertility treatment in PCOS patients. Just to summarize, before you embark on any treatment in PCOS, see that their lifestyle management is done, that they are trained in exercise, diet, sleep, and a good quality of life. They reduce the stress and the oxidants present in their body. They reduce their weight. And once this is done, we embark on the ovulation-inducing treatment. The first line of treatment is oral ovulogens, either aromatase inhibitors, or if that fails, clomiphene citrate. And we can add metformin to both aromatase and clomiphene citrate and monitor ovulation with ultrasound and advise planned relations. If this fails, we have two other options, laparoscopic PCO drilling, or we have use of low-dose step-up protocol of gonadotrophins. Low-dose step-up protocol of gonadotrophins can continue for 20 to 21 days. We start off with 75 IU of FSH and gradually keep increasing it every week, looking at the size of the follicle. The aim is to get a monofollicular growth. If we have multiple follicles growing with gonadotrophins, it's better to cancel the cycle or convert it into an IVF cycle. Then if this does not work, we go for laparoscopic PCO drilling, and we should inform the patient of the possibility of intraperitoneal adhesions or peri-ovarian adhesions as an iatrogenic thing produced by PCO drilling in some patients. If all this fails, then these patients are for IVF, antagonist protocol, agonist trigger, freeze all, and transfer in the next cycle is the best strategy. Adding metformin to these patients helps in prevention of miscarriages. And IVM, as on today, has not got that status in the treatment of PCOS as the antagonist protocol and freeze-all procedures. I think this is how we can treat our PCO patients, and almost 90 to 95% PCO patients have excellent fertility results. These women are full of eggs. The only thing is one good egg has to come out, and their body has to be in a good condition to carry this pregnancy to term. Once conceived, these patients can be at risk of diabetes. They can be at risk of miscarriages, PIH. They can also be at a risk of complications, later complications in pregnancy because of obesity, and all this should be managed. Thank you very much.
Thank you so much, Dr. Jilla, for that very detailed presentation. We do have a couple of questions for you before we close this session. The first question that we have for you today is, what are the risks and benefits of different medications used to induce ovulation in PCOS patients?
About the medications used for ovulation induction, letrozole is a very safe drug if it is effective. Secondly, clomiphene citrate can produce multiple ovulations and may fail in giving you a pregnancy because of the adverse effect on the endometrium, but it's a powerful drug. Gonadotropins can be a double-edged sword. While you can get ovulation, you can get multiple ovulation, you can get multiple pregnancies, and you can get ovarian hyperstimulation syndrome. Therefore, gonadotropins should be used extremely carefully in patients of PCOS. Laparoscopic ovarian drilling needs an expert surgeon, and also we have to be aware of the complications intraoperative, pre and postoperative, and also the anesthesia complications associated with laparoscopic ovarian drilling. And when it comes to IVF as a treatment, when all other treatments fail, then the best treatment is antagonist protocol, agonist trigger, freeze-all, that is cycle segmentation, and transfer in the next cycle.
Thank you for that response, ma'am. The second question that we have is, how can anti-Mullerian hormone levels be used to assess ovarian reserve and predict fertility in PCOS patients?
Well, there is a cutoff. More than 4.5 of AMH, we consider these women to have polycystic ovarian disease. Higher the AMH, more, like they are going to have many more follicles than the ones with lower AMH. It actually tells us or reflects the number of follicles which will grow with gonadotropins in PCO patients.
Thank you for that answer, ma'am. The third question, how can healthcare providers offer emotional and psychological support to women with PCOS who are struggling with infertility?
In this, I'll tell you, the best thing is lifestyle management. And all PCO patients should be advised, like, you eat every day, you sleep every day, you must exercise every day. This just changes the pattern of their life. And the exercise should be resistance exercises like weights, climbing, or then, very heavy exercises like Zumba or swimming. So, which helps them in reducing weight. And as far as their diet is concerned, they should have diet which is rich in fiber and proteins and low in fats and carbohydrates. They should take small meals at a time. They should have good sleep. They should avoid stress in any form. Just these simple things may, allow spontaneous ovulation and conception in these patients. So, but they have to be very religious with their exercise.
Thank you. Thank you for that answer, ma'am. The final question before we close today's session is, what is the optimal long-term management strategy for PCOS to address both immediate concerns like fertility and the potential for long-term health complications such as cardiovascular disease and diabetes?
Very true. Again, I come on the same points. The first thing is they have to learn to live with polycystic ovaries. Because polycystic, they are born with those ovaries, they have to learn to live with the ovaries. And for this, they have to maintain a pattern in their life. That is, they should be regular exercisers. They should be exercise lovers. The more they enjoy exercise, the better will be their life, the quality of their life. Secondly, they should not be food lovers. No, they should be simple eaters, like, simple home food, lot of fiber, lot of vegetables, lot of proteins. not going for the palate, but going for the quality of the food. The third thing is, if they are obese, metformin can be started early in these patients, even if they are not diabetic. Metformin with vitamin B12 will help them in reducing hunger, in reducing weight, and get having a better feeling about themselves. It will also reduce hirsutism, and young adolescent girls will feel much better when they are taking metformin than when they are not taking metformin and they are obese, they have hirsutism, they are dull. Besides that, these women also have other endocrine problems like hypothyroidism, which should be dealt with as early as possible. And they are, they are prone to depression, anxiety, hypertension, and diabetes. So this should be always checked, at a 3-monthly or a 6-monthly interval in these patients.
Thank you. Thank you so much for all your responses, ma'am. That was the last question that we had for today's session. To all our audience members, thank you so much for your active participation in today's talk. We will be back with another clinically relevant session next week as part of our Master Series session. Thank you so much, Dr. Jilla, for making time for this presentation. It was indeed very insightful listening to you. Thank you once again from the entire team of Doc Plexus. Thank you. Have a good day.